Shall we start?
Yes.
Good evening, everyone. Welcome to the 12th lecture in the Golden Jubilee lecture series organized by the Medico Pastoral Association, Bangalore. I'm Reshma. I work as a counselor here at Medico Pastoral Association, and I will be your MC for this evening. As most of you are aware, the Medico Pastoral Association, registered in 1972, is the first non-government mental health organization in India and is credited with pioneering work in the field of rehabilitation of persons with mental illness. Locally and nationally, MBA is well renowned for its contribution to the field of community mental health, particularly in the area of educating people about mental health issue. This year marks 50 years of distinguished services, an achievement that the Medico Pastoral Association wishes to celebrate with everyone. On many programs being organized to celebrate this Golden Jubilee year in a series of lectures organized each month on various aspects of rehabilitation, well-being, and mental health. We delighted to have Dr.T.Murali, Professor, Head of the Department Psychiatry, MS Ramaiah College, Medical College, Bangalore. Also, MBA's Managing Committee member, who now serves as a chairperson of the Admission and Discharge Committee of MBA, to deliver the 12th lecture in the series. The session will be chaired and moderated by our President, Dr. Joseph George. Now, I would like to request the staffs and the residents to lead the group prayer. Over to you.
You need to unmute. Please unmute, then the prayer will be heard.
Amrita, could you unmute, please?
Someday we walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall live in peace, we shall live in peace, we shall live in peace someday. Oh, deep in my heart, I do believe we shall overcome someday. We are not afraid, we are not afraid, we are not afraid someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome someday.
Thank you. Now I request that Dr. Ajit B. Bide, Senior Psychiatrist and Honorable Vice President of MBA, to welcome the gathering. Dr. Ajit B. Bide has been associated with the MBA for over 2 decades now. Over to you, Doctor.
Thanks, Reshma. It gives me great pleasure to be here on the occasion of the 12th and what might be the final Suvarna Jayanthi lectures that we have. I say might be because we have a proposal to continue this lecture series, which seems to be very popular both among mental health professionals as well as other people who are interested in mental health. Thank you, all of you, for being here. It's my pleasant duty to welcome you to this, the 12th lecture in the Suvarna Jayanthi lectures that we started in February last year. Our actual Jayanthi falls in the month of August, so we started 6 months before and we are going 6 months after. The first lecture was delivered by Professor Mohan Isaac, who has been the soul of MPA for the last several years. He spoke on the rehabilitation of the mentally ill, the story of the first mental health NGO in India. Then from Chennai, Dr. Padmavati, director of the well-known NGO SCAR, spoke to us dealing with schizophrenia, what matters most to the woman. We chose this topic because we were also decorating two of our eminent women members and office bearers from the past. The third lecture was delivered by the eminent Professor Dr. Srinivas Murthy, who spoke to us on spirituality and mental health, a neglected resource of India. The fourth lecture was delivered by Dr. Sanjay Phadke of Pune, who spoke on mind-body medicine and mental health. The fifth was delivered by me on mental well-being and mental illness, the role of parents. The sixth was by Ms. Ratnaboli Rai from Kolkata, a very well-known activist. She spoke on mental health activism, a personal journey. The seventh lecture was by Dr. Avinash, I should say Professor Dr. Avinash D'Souza from Mumbai, who spoke on understanding and managing the badly behaved child. The eighth lecture was delivered by Professor Dr. Pratima Murthy, director of NIMHANS, who spoke on her area of specialization, addiction and mental health. The ninth lecture was delivered by a close friend of MPA, Dr. Kalyana Sundaram, who spoke on mental health, a veteran's journey and lessons learned. The 10th lecture was delivered by our own Dr. Matthew Verghese, who spoke on preventing mental disorders in the elderly. After having shied away from the limelight for a long time, our president, Dr. Joseph George, who is chairing today's lecture, delivered the last lecture, that's the 11th one, on faith and health, psychological and clinical explorations. This was a very erudite presentation which included clinical case material relevant to the issues. And now it gives me great pleasure to welcome my dear friend, Professor Murali Tailoth. As you heard, he is a professor at MS Ramaiah Medical College, a very popular teacher among his students, a very popular healer among patients, and somebody who has done pioneering work in the field of mental health. I won't steal Dr. Joseph George's thunder by giving you all the details of Murali, who will be introduced formally by Dr. Joseph George. But we're very proud of the fact that Murali was an international president. He was the president of the World Association of Psychosocial Rehabilitation, the first person from India to have held that very important post. Murali has been working in the field of rehabilitation right from his earlier and enhanced days. For over 30 years, he has been in the field, and he does his work quietly without much shosha. That's all I'll say for the moment. A warm welcome also to our hosts, the Microlab people led by Mr. Ganeshan. And on behalf of the entire staff and office bearers and members of the Medico Pastoral Association, welcome to an evening of erudite presentation and hopefully a fruitful discussion. Thank you, Reshma, for giving me the opportunity to welcome the gathering.
Thank you, Doctor. May I now welcome the Honorable President of MBA, Dr. Joseph George. Dr. Joseph George, former Head of the Counseling Department at United Theological College. He is a well-known professional counselor, clinical supervisor, and educator. Sir, thank you for your presence. And now I would like to request that you to introduce the guest speaker, share the session, and also facilitate the discussion and Q&A after the lecture. Over to you, sir.
Thank you, Reshma. It is an honor for me to introduce and welcome Dr. Murali Tailoth. I have known Dr. Murali for the last 30 years. That's what I realize now. When I joined UTC faculty, 92, I think 93, 94, that year, I also came to MBA along with Carlos and Saroj Welsh. So whenever there is a program, always was there. And occasionally I used to meet Dr. Murali in different committees. And one committee I remember was Dr. Murali was the chair for therapy and program for 2 terms. I was a member. So, that was a close interaction. It's a small committee, about 4 or 5 members, but a lot of interactions about MBS, clinical rehabilitation procedures. And I observed Dr. Murali very, his way of handling things, the professional wisdom was very evident in his interactions, supporting, encouraging, and helping people to see how they can view this from a little more wisdom. And whenever he disagrees with something, he never says, no, I don't think that's a good idea. He always asks 2 or 3 questions, and the committee members will change the plan because they realize that this is not the way. So this is what I call the professional wisdom in mental health management, particularly psychosocial rehabilitation. The Medico Pastoral Association is fortunate to have many, expert professionals as part of the officers and MC members, starting with Dr. Mohan Isaac. And in a recent chat in the MC, there was a sharing of information about 1998, 99. There was a group of experts who were gone to 39 mental health institutions, studying, assessing, evaluating, making a report. And I understand Dr. Murali was part of that, along with all others who are also part of MBA management today. And so that is something very important. So, I want to say how MBA is so blessed to have so much expert with us in terms of helping the facility to go well. Now, Dr. Murali is known as a teacher, researcher, and practitioner in psychosocial rehabilitation. He nationally and internationally well-reputed scholar and mental health practitioner. I was looking at the researchgate.net that says Dr. Murali has 78 published articles, which are academically and empirically research articles to his credit, alone as well as along with others. This I consider as a big achievement. So maybe there are others which we do not know, but at least 78 is there. So this is a well-deserving kind of an appreciation for his work. As Dr. Ajit said, he was the immediate past president, World Association for Psychosocial Rehabilitation, which is a reputed international position. He was also the vice president, Indian Psychiatric Society, Karnataka chapter. He is the secretary, Chattadama, HT Kotra, Karnataka. He is also advisor, Rehabilitation Speciality, Indian Psychiatric Society. Such a person with a lot of positions to his name, as well as service to the community. We are so fortunate to have Dr. Murali with us for the 12th lecture to be delivered. Dr. Murali, it's an honor to invite you on behalf of MBA to deliver the lecture. Over to you, Dr. Murali.
Thank you, Mr. President, for a wonderful introduction. And I'm extremely grateful for all of you to invite me to give the 12th lecture. And respected teachers, Dr. Srinivasamurthy, Dr. Mohan Isaac, and my senior colleague and good friend, philosopher and guide, Ajit. it is something very difficult topic, which when I talked to Ajit, told me to talk about. And I have tried my level best to see how this could be brought together and put it into one piece. But before getting into that, can we go to the next slide? Now, we'll go to the next one. Now, this is something very, very interesting. The Golden Jubilee year, that means 50 years. It's not an easy task for any organization to sustain for so many years and growing and growing and growing. And at this juncture, I would like to say that this has happened with the help of so many people, and Dr. Joyce Shiromani, who founded MPA as the first halfway home in India, has been a big force behind the program everywhere, and she has influenced a lot of people. At the same time, you will also see that Joyce, after leaving this place, started Paripurnada in Calcutta. Where I was also, even today, I was associated with that organization. And it's great to remember Joyce Shiromani for her contributions. I feel that we also have to learn a lot regarding humane approach to the persons with mental illness. And there are many other people who have helped over a period of time in the MPA, like Air Commodore Chaco, Mr. Martin, and Dr. Carlos, and Sarah Welsh, Vicky, Dr. Jovita, Dr. J. Alexander, staff members of various periods, volunteers, donors, and a large number of volunteers and people have helped for the growth of MPA. And that is the one strength of MPA, which I have observed, is that there were ups and downs, but at the same time, the foundations were very, very strong, and we could go ahead and reach the stage of 50 years. And I wish that we will be able to move forward for another 50 years. Next one, please. Now, why this topic? Some of the reason is that on the way, you will all realize that why this topic has been significant when we talk about humane approach. This might have been the talk happening about so many centuries back also, about how to treat mentally ill person with a humane approach. But even today we are talking about that. One of the reasons is stigma, the vulnerability of this population, and intolerance of others for the behavioral disturbance of individuals, and socio-cultural and religious factors, and non-alignment of the awareness, accessibility, availability, and affordability and acceptability. These are the more things which is creating an issue for people with illness. Next one. Now, this is a paper which came yesterday, Deccan Herald, Mental Institutes in Deplorable Condition. As our president has introduced at the time, that 1998, we have been talking about this inhuman conditions of mental health institutes and the acute shortage of doctors, not only doctors, a lot of other allied professionals, and still even we are in the same stage. Not much of improvement has happened because of this report which comes in, where NHRC has gone directly. Next one. Now, before getting into the next other thing, I thought it's important for people to know that what is actually the allocation of funds for the thing. Just a little digression. 1992 is a rare mention of mental health in the budget. While the focus on mental health is welcome, concentrating on only a few institutions will affect the quantity and quality of mental health services extended. Next one. Now, this figure, you can see that two major institutes in the country garners the maximum amount of funds realized. I am very happy that NIMHANS is getting a large chunk of it. because we all still depend on Humane for a lot of our thing, and Humane guides us in various activities of mental health across the country. At the same time, LGB Institute in Tejpur also is getting a substantial income. But if you look at the expenditure which is given from the as part of the health expenditure for mental health, only 0.81%. And of course, in the recent past, there's been overall allocation has increased, but I'm not very sure how this is going to be very, very effective. Next one, please. This is the problem. Now, if you look at it, whatever allocated has not been able to be spent. That is a very, very serious issue, which you have to look at it. There must be some issue of why it's not being utilized. Questions are there, answers have to be arrived at. Next one, please. So thousands of another news item which talks about thousands of mentally ill people chained like cattle for years in sheds. This is again a recent one which is there available in the public domain. And here also they quote Article 21, every person with mental illness shall not only have a right to live with dignity, but shall be protected from cruel, inhuman, or degrading treatment. This came in the outlook. Then see, look at this, where the there is not sufficient space for people to have. There is no personal space. Next one. And abandonment in the family. This is a very common thing which is happening, and especially we have the experience of working with Chittadama, which is our center which we run for person with mental illness who are homeless. Next one. And even today, people are chained and bound. And this is as Professor Srinivasamurthy, when he used to talk in the past about these type of things, I never used to believe that. After seeing some of the things, it started believing really. And I'm not showing some of the other pictures like Aeroadi's picture and all, which people have seen. Next one, please. Now, faculties in psychosocial rehabilitation, the same sites, who are the key people who are involved in the care of the mentally ill? Initially starting with individual, then the family, mental health professionals, NGOs, community at large, and the state, which is a very, very important player in the field. Next one. I thought I'll start with two case winners. First one is Mr. X, a young man from a middle-class business family, 19 years old when he first started hearing voices. The voices were abusive and threatening, and X was constantly frightened and suspicious of his surroundings. He stopped going to college, was distrustful of his own family. His behavior worried his family, and they took him to the psychiatrist, and a diagnosis of schizophrenia was made. Next one. Next one, please. What does family do? This is something very interesting to look at it. Initially devastated by the diagnosis, but family supported the patient. Ensured treatment compliance, encouraged to interact with people without feeling embarrassed, and did not isolate him. Realized Mr. X is unable to complete education, send him for a daycare rehabilitation, encourage him to do simple tasks on his own. Next one, please. Mr. X gradually recovered, lost skills, and developed new ones. Once psychotic symptoms were under control, started getting him involved in family business. Today, after 20 years, Mr. X helps his brothers with the business and takes care of his elderly mother. Mr. X brings groceries on the market, interacts with people on a regular basis without fear or worry. He's on maintenance medication, but still continues to hear voices. This we can always call as a functional recovery. With the support of family, doctors, and community, patient has learned to move beyond symptoms and become a fully functional, valuable member of the community. But we do not have to be afraid of the symptoms. Next one. What was done right? At an individual level, he put in efforts, took the treatment regularly, and was willing to learn and adapt. The family level, there is a complete support, ensure timely intervention, and actively try to integrate him into society. Mental health professionals provided adequate, appropriate treatment and psychoeducated the family. Daycare rehabilitation facilities were utilized. Community accepted him without judgment, gave him opportunities to be a useful member of the community. This case, I would like to dedicate to Professor Robert Paul Lieberman, who was my mentor, and his idea of biopsychosocial model, which really fits into this particular successful case. Now, the other extreme, we can go into the next case, case V2, 21 years old, first episode of mania, aggressive, violent, and rash. A female came from a well-educated middle-class family, admitted to a psychiatric facility, and treatment started. After discharge, the family started viewing her as a burden and was embarrassed and did not allow to interact with friends or family. Family did not ensure regular medication, neglected and left on her own and not encouraged to work. People in the surrounding ostracized her and called her by various names and terminology commonly colloquially used for mental illness. Disability increased with every passing year and gradually lost many skills. Number of manic episodes increased, and eventually she was abandoned by family and ended up in a chronic ward in a government hospital. Now, what went wrong here? Lack of family support, nobody to ensure regular treatment, poor integration with community, ostracization and name calling by the community, rehabilitation facilities not utilized to regain lost skills, lack of humane treatment led to the poor prognosis in what could have been an easily manageable condition. Next one, please. Now, let us look at the common attitudes of the family. I am not going to enumerate everything what happens, but it's just basically to highlight on this. Patient is always a patient. Opinion of the patient is not taken, not listened to, not given responsibility or involved in decision making. Is not taken for any functions. Rights not respected. Is subjected to domestic violence, actions criticized and put down. And this happens in majority of families. And here I would like to show that there is a happy reunion where the family has accepted a person who was homeless and now very well settled. Next one. Now, attitude of mental health professionals. Unequal transaction. I am the boss. I know all about you and your condition. Listen, do what I say. Unknowingly, patients' rights are violated. This is not only with some professionals, most of us inadvertently get into this thing. Of course, the person is there, there's a disability, so he needs support and help. But that is not. It is not that they need that type of a support. We have to actually have a ideal situation is that have a equal transaction between the professionals and the mental health, mentally ill person, and try to accept him as a human being rather than a person who has got disability. But there are some exceptions to this. There are plenty of professionals who are now very, very rights oriented and getting very close to the thing. But these are the points which I mentioned to be very careful. Now, attitude of the NGO. This clipping is today's newspaper. Mental Health Authority to probe the death at a de-addiction center in Bangalore. And so the attitude of the NGO, charity model is there, disability model, religious model, NGOs run by untrained recovered patients, which is this report which shows people who are addicted to substance. They say that we are recovered persons and we are running a facility. And that is where this has happened, and Mental Health Authority has appropriately taken the necessary steps to go into this. And major issue is the persons with mental illness who are homeless. And I remember when I joined my work with rehabilitation in 1986, there are a handful of NGOs working for persons with mental illness who were in families. But today you can see at least more than 300 agencies across India facilitating work. But at the same time, there is no uniformity. Record keeping and materials are not being maintained very well due to the large number, because there are some centers in Kerala where there is 300 to 400 people are being housed, and when they recover, they are being sent back. And the place in Karnataka where we manage in Hegdedevan Kote, the Chittadama Center has got facility for up to 50 patients, but we are having 39 at present. And the moment they recover and give the address, we send them to their own facility. Next one, on houses. Now, issues are there with the NGOs. One is lack of infrastructure, lack of facilities and trained personnel, abuse in institutions, physical, sexual, and verbal, and neglecting genuine complaints and physical illness sometimes missed. Most of the time, even in NGOs, they also become almost like institution, like a hospital where patient falls lowest in the hierarchy. They cannot take a decision, they cannot do that. And exemption to this extent, a large extent, is the Richmond Fellowship Society. It's an example which I can talk about it because it's run on therapeutic community approach and started by Eli Hansen. And today we had a reputed speaker, Dr. Kalyan Sundaram, earlier on this program. And we do that. Especially in places like MPA, what we follow is more of an eclectic approach, whichever is being suitable, and the patients have rights and freedom as is possible. And then next one. Now, this is something very, very in the awareness availability. This is something which all of us have to really look at it and then start commenting on why this is happening, why that is happening. Next one. Now, awareness. This is an awareness program which is being run in one of the centers in Tamil Nadu. I can give multiple examples of good awareness program associated with temple festivals, mosque programs, or with church activities, which is much more acceptable to people. And we also have done a lot of program in the past 10-15 years in the state of Kerala, as well as Tamil Nadu and Karnataka in different forms. And today you can also see that. Next one, please. In schools, multiple things. It has actually definitely grown, and it is going to grow much larger, especially the inputs from various mental health groups, especially from Indian Psychiatric Society. Karnataka chapter is doing a lot of educational program, school health, as well as community health by different members of the society. Next one. Now, I thought I'll just talk to you a few examples of the reactions of the community. A community where there is a very good awareness programs on regular basis. This is an example of a person who was homeless, was brought to our center, where our staff in the region has been interacting with a lot of community workers, and we are involved with the 8 panchayats there. And this young boy was 22 years old, developed treatment-resistant tuberculosis. He was having that treatment-resistant tuberculosis when we rescued him from the road, and he was treated in various places, including Ramaya, and we could not save him, and he passed away in our center. And for his funeral procession, more than 300 people participated from the local community to have a decent, dignified burial for him. This is where the if community is very much acceptable for the program, it's a success which you will see. The other one is that in this center, few of the centers, we can also see that full community participation in rehabilitation centers, where centers are open and community members can come and interact with the person. Now, this is something very, very important. The inadvertent usage of colloquial word. Now, this year's Mental Health Day observation by celebration by WHO, as I was also part of an invitee for that program, they have talked about the number of words which we or phrases which we use in a common language to address a deranged behavior. And what are they? So it is something like mad person, nuts, So these type of words should not be used, and we should be careful. And one classical example of this happened. I can narrate the story. This was a person whom I interviewed in 1998. I do not think that things have changed much even today. The community, as part of the Human Rights Commission's visit, one of the hospitals, we saw a ward where 6 patients, beds were there, and 4 toilets, and all the toilets blocked, and it was filled, and there was no drainage. And there were 16 patients in that ward, and there was a lot of food material piled up outside, which was smelling, and none of us could bear that smell and sight. And one young boy came and told that I just came back. So I had to ask him, what made you to come back to this place? So he said, my friends rescued me when I had a problem, an acute excitement, in the sense that he was violent. He was brought by his friends and relatives, go to this ward and got him admitted. And after treatment, he recovered, and the doctor told him that you can go back and start working. He was so happy, he went back and opened his the shutters of his shop, and he overheard other people saying in the local language, the mad person has come back and he's opening the shop. Immediately he closed the shutter and he came back, rushed back to the hospital, which is a little far away, caught a bus and came back and told the doctor that this hospital is this place where I stay is better than the world outside. I think this is something which we have to take up and learn a lot from this type of reaction by the person. And that is where we have to actually look at what happens with these people. Next one. Now, this is something which is very, very significant, actions by the state. And now today we are having the Mental Health Care Act, which has a rights-based, person-centered protection of rights, provisional treatment and facilities, residence for persons with mental illness who are homeless, district mental health program. Now, these are all there in letter and thing, right? I do not know whether it is in the spirit, because a lot of places we will find on the way, we'll find what are things lacking, and issues like residence for persons with mental illness who are homeless. 3 days back, not 3 days, 2 days back, part of the NHRC report is that they have questioned that what happens to the people who are recovered. You cannot keep them in an institution. We also face these issues. In our center, there is no other facility where a recovered mentally ill person can go. The Act says that it has to be done by the state government to develop facilities for that. And there is initiatives in Karnataka, which is hopefully will come at a good pace. Next one. Rights of persons with mental illness, Chapter 5 of the Mental Health Care Act. Now, all type of services, OP, IP, rehab to be accessible, affordable cost, quality, free treatment for the needy, long-term care in mental health establishment, that is called the MHE. Then the section 19 talks about right to community living. Section 20 talks right to protection from cruel, inhuman, and degrading treatment. Safe and hygienic environment, adequate sanitary conditions, facilities for leisure, recreation, education, and religious practices, privacy, proper clothing, no uniforms. This I would like to give an experience which I had. That is a time when we were just with my colleague Dr. Kiran Rao, we were in Gujarat, and the health minister, Mr. Ashok Bhatt, asked at that time, doctors, you have come here. Can you tell me one thing which will come as a headline tomorrow? I requested him, sir, if you just announce that there are no uniforms from tomorrow onwards, it will come as a headline. He did that, and it came as a headline. And that day onwards, there was no uniforms in all the mental hospitals in mental health institutes in Gujarat. No forceful work, provide remuneration. This actually is very interesting. 1936, there was a manual prepared for Tezpur, Agra, and CIP Ranchi. In that, it is mentioned that no patients in the hospital should be forced to do the work. They should be encouraged to work and provide 1 rupee remuneration. That's very, very significant in that particular thing. And this particular document is available only in Tezpur hospital. Protection from physical, verbal, and sexual abuse is mentioned in the right to protection from cruel and inhuman degrading treatment. Next one. 21 talks about right to equality and non-discrimination. No discrimination on any basis: gender, sexual orientation, religion, class. And now, to some extent, we can also say that sexual orientation is a very important issue, because we are one of the hospitals where we have a system in place for gender affirmative procedures, including hormone treatment as well as surgical interventions. Emergency facilities, ambulance services, living conditions, mental health establishment, insurance for persons with mental illness. Insurance for persons with mental illness is a issue which needs a lot of debate, and just by mentioning it may not work out, because most of the insurance companies are interested to see that how they cannot pay the person insurance. I would like to state it repeatedly, no issue about that. And we have not got different guidelines for what should be the insurance payment for mental illness. Now the issue will come on evidence-based treatment for mental illness. Now, what I wanted to give as a question for people to think about is that, can we quantify this evidence-based thing in psychotherapy or psychosocial interventions? The current method of measuring the evidence base is more towards a drug trial basis, and probably we may have to develop new methods of assessing the efficacy of various psychosocial intervention, and which of late I have been pondering on this, whether to provide the insurance company that these are the things which needs reimbursement or which needs support. So that those things have not been worked out, and I am sure that mental health authority or various people can look into that. Persons with mental illness and nominated representatives have rights to following information: reason for admission, review admission procedure, treatment procedure. Very clear. These are the 3 areas where nominated representative have been intimated on this. Next one. Section 23 to right to confidentiality. This will again, I will come a little bit on the postscript. Duty of healthcare providers to keep information confidential. And it is a duty of the healthcare providers. Suppose if confidentiality is breached, the person has a right to go and sue the healthcare provider. So all of us should be very, very careful about this aspect. Exceptions are nominated representative, other healthcare providers, danger to self or others, medical emergencies, in the interest of public safety and security, and judicial proceedings. Other than this area, we cannot divulge any information. Next one. Section 25 talks about right to access medical records and right to personal contacts and communication, which is very, very important. The person can use cell phones. Access to phone is very, very important. Right to legal aid, right to make complaints about deficiencies in provision of service. Next one. So we are having excellent rights which has been talked about, and WHO has launched what is called rights of persons with mental illness. It's basically a good approach towards, rather than new approach, the approach community mental health, person-centered and rights-based approach, guidelines to end human right violation in mentally ill patients, online quality rights training for all across the globe. The target of WHO is to train at least 500,000 people, whether of all backgrounds, on this online quality rights training, and started in various countries. And in India, Patare has done the work in Gujarat after going the training. We'll show you that a little later. After going the training, he had done a pre and post assessment and found out that this training has given a lot of improvement over the maintenance of the rights of the person with mental illness, and people enjoyed the thing. And this training program, actually, few of us have gone through that. And the WAPI, World Association for Psychosocial Rehabilitation, has got a rights being training being headed by Professor Michaela Amring, and we are going ahead with the whole process of getting into a lot of people as a partner to WHO. And I would like to, next one, please. This is the link, and all the participants, and they can be shared, and this is a public link. You can enter into the thing. The moment you complete the training, you'll be getting a certificate that you have undergone this training. Takes 5 to 15 hours maximum, and no need to do continuously. It can be done. You can finish part of it and come back and again go back. You can restart from the place you have left behind. And your name and details will be registered with the WHO. Next one, please. Now, points to ponder. Now, this is something which happened last Sunday when my colleague, senior colleague, Dr. Ravi Shankar Rao, was the chairman of the Chittadama, and I was there in Hagdadevan Gote. Family and friends tie a patient and bring to a rehab center in a rural area. And as per the rules, which we cannot keep any medicines or anything unless there is a pharmacy. So we used to have any emergency situation comes, we used to get it on the neighboring hospital, private facility. But on that particular day, no injectables were available anywhere in that place, and including private pharmacies as well as taluk hospitals. And we do not know, that particular day nothing was available. And we had to actually, our staff has to contact Mysore and try to send the patient there. Then the question comes is that tying a patient by the relative, because he had made a lot of disturbance and beaten up relatives and things like that. When you do not have a facility to take care in a rural area, I think this is something, the question comes in, whether whose right is important, what is happening. I do not have an answer. I think that is open for things to ponder. Now, coming to the thing, all the HO departments, they had a training conducted by NIMANS and the Mental Health Authority and the Health Department of Karnataka. Excellent program and a very, very ambitious and great program. Like trying to train us to, and I'm sure that our Secretary of Medico Pastoral is also there, and we were trained to enter chief complaints, details of the patient, and everything in a e-portal so that others can reach. Now, when you are uploading anything in the internet, please remember, whatever password, whatever it is there is no confidentiality. Now, excellent program, ambitious program, great effort, but questions are there to be answered. Is it actually right with the Mental Health Care Act? Are we violating? Because the only thing in that training was told us that you can register the telephone number of the patient who comes, and the patient will get an OTP, and that OTP is considered as a consent. Now, questions can be raised about the consent. Is it sufficient enough? And is that enough to say that patient has consented? So there are a lot of questions to be answered, and I hope that all this. And secondly, it takes almost an hour to complete the whole process. I hope that something better or on the way, things will improve. And because Karnataka has been a leader in various activities of mental health, including community psychiatry, rehabilitation, and our national institute staying there, and first halfway home, first daycare center by volunteers, the Friends of Nimans. So all these things have happened in Bangalore, and I hope that this Humane portal also will look into all these issues. And I would like to thank once again and stop here. Thank you once again.
Thank you, Dr. Murali, for that very profound, detailed explanation of the humane dimension of mental health, and particularly giving us examples how the professional psychiatric treatment can even fail when there is no human dimension, which is something very important for all of us, for MPA too. And thank you so much. Now, I would open the floor for your questions and discussions. There is a request. Is there a possibility of sending this bullet point by email later? Okay, that is from George Varghese. Father George, we have the recording will be available. So it is entire talk will be available for you. So, Dr. Ajit.
Thank you, sir. Dr. Murali, you raised some very valid points right at the beginning when you spoke about budgeting, and that mental health got a mention was really laudable. But you had some reservations about the institutions being given the grant. How would you have liked to reframe the availability of these resources if you were to decide? One question. Second thing, you rightly pointed out of the path to health, they say, is paved with good intentions. So this e-Manas thing, I think the intention is very good, very human rights oriented, but I think this is going to spoil the entire scenario by compromising the patient's dignity. I'd like your comments on these two aspects.
Thank you.
Can I answer that?
Yes, Dr.
See, the first one, Ajit asked me, given a lot of freedom. If I would like to say that because the government says that 704 districts have already got the district mental program. I'm sure if I'm wrong, Professor Murthy is there who can correct me. I would like to say that the maximum amount of money I will put on this 704 districts. If we're looking at deinstitutionalization, Taluk Hospital for acute care, and the community psychiatry movement is the thing which can come. Then we may not even need much of separate rehab institutions or this thing. That's what first one. E-Manas, I also have a lot of doubts because most likely if you do this, there can be a lot of litigations which can come up. That is one thing. And I would like to keep it open because as rightly you pointed out, the way to hell, the intentions are good, but the path is there. I hope I have answered Sajid.
Thank you, Dr. Murthy. Father George Varghese, and then Dr. Srinivasa Murthy.
Am I audible?
Yes.
Okay. Thank you, Dr. Murali, for your informative talk. This brings back my memories as a BD student of UTC way back in 1975 to 79, when I was associated with MPA and Halfway Home. It was at the beginning stage when Dr. George Siromani was a secretary, and I had the privilege of doing a case study of a schizophrenic patient. I don't remember the details, but I still have the thesis with me. Anyway, my question is something different, but still related. Many religions, including the religion of which I am a part of, Christianity, still consider the mentally challenged people as possessed. So can you address this as a person from this field of mental health? Thank you very much.
Thank you,
Actually-
Dr. Murali.
Actually, it's a very, very valid point. Lot of religious beliefs are there. And there are some models currently in the country which talks about that, okay, Diva and Dua program from Gujarat. Then we are having Murugumali Dargah where they have appointed a psychiatrist, and follow-up is very good because some other reports have come that it's very good. Similarly, I think that we are having one of the good person who can talk about it, experienced person. Solomon from Africa will also say that these are the similar things what he finds there. And I would also like to have solely to answer few of these things, the faith healer issues and religious things.
Thank you.
Very, very common.
Dr. Murali.
Thank you very much. Thank you, Murali. It was a panoramic view of the development of rehabilitation from the very, very micro level case histories to the macro level like Himanas, and I think it's a very good. Thank you very much. The human aspects of it came back to me, someone whom all of us remember is Joy Shiromani. It was 30 years back when the mentally ill in the jails of West Bengal was being studied, and we were appointed, Dr. Amita Danda and myself, as commissioners. When we went there and we saw what Joy was doing it at that time, Joy Shiromani was doing, I still remember the discussion I had. I said, what is the most challenge? She said, Dr. Murthy, I know it sounds a little hard, teaching these people who have been in the mental hospital how to use the toilet, and I spend a lot of time. And when that occurs, then you see a tremendous transformation in them as human beings. So there is a whole lot of things that needs to be done in this one. The second thing which I personally feel urgently needed in the area of rehabilitation, including MPA and other places, we need to document what is it that's happening about illness, about the families, about the community that is leading to chronicity or recovery. I mean, this has not been documented. I've talked about it again and again. We need to really, everyone is not needing rehabilitation. Everyone is not needing institutionalization. What is it? And what is it that we can do, not only at the medical level, but at the social level to prevent this occurring? I'm told, I hope I'm not wrong, that Kerala has more psychiatric institutions than the whole of the rest of the country. Good in one way, but otherwise, why is it happening? What does it mean? Do we want to go in that direction? These are bigger meta-level issues. I don't have an answer, but I think we need to ask. And Murali, thank you very much. You really opened up the picture in a big manner and made us wiser and think of acting at various levels. Thank you very much, sir.
Thank you.
Thank you, sir.
Okay. Any other questions? Yes, Dr. Ajit. Unmute.
I want to respond to Father George's comments. It was nice to know that I did not know that Father George had such a long association with MPA right from Dr. Joy Shiromani's time. What he spoke about possession is still a very, very prevalent belief. I'm sure Solomon will have more to say. Sorry to butt in like this, but this happens even in my religion, the religion I'm born into. It's fashionable to call it Sanatana Dharma now. But the idea that possession underlies all mental maladies is very common, right from mental retardation, which we now call intellectual disability, to frank psychosis like schizophrenia or severe cases of affective disorder. There are shrines of every religion specifically dedicated to some form of prayer and exorcism. For my religion, I know in northern Karnataka, more of a Maharashtrian place, Gangapur, where the famous Dattatreya temple is there, people go and stay there for months, expecting the exorcism to work. And I don't know if the situation has changed, because my information is from about I kept track of it till 2010, when my dear friend Sunanda passed away. She had been doing research over there. I think this is a pervasive belief which we have to gently fight. Another friend of mine very nicely put it, time was when lunatics were burned at the stake as witches. Now we've reached a stage where instead of burning witches, we are burning molecules with more molecules. The unfortunate part is that while biological psychiatry has given us very exciting developments, the humane touch, what Murali was talking about, has been compromised way too much. Today's psychiatrists, I'm sorry to say, are expert prescribers, but they're losing the skills of individual relationship, communication, and therapy.
Thank you, Dr. Ajit. Any more questions, any additions that you want to make?
We're waiting for Solomon's inputs.
Solomon,
Yes.
unmute.
Yes,
Yeah, I don't-
continue, Solomon, we can hear you.
Yeah, I was saying that I have very little to add, because Professor Murali has summarized most of the issues, but just to share some common issues with some of the slides that he presented. In a number of African countries, including South Africa, there are still areas where patients are chained and bound, and this is creating a problem, despite very good mental health care acts on paper. The implementation of these mental health care acts is a problem. There's also an interesting perspective here, now that this is medical pastoral care, that in South Africa and many African countries, there are more churches than mental health care institutions. There's a movement towards people collaborating more with the churches and religious groupings to provide support to the mentally ill patients. But if you go to countries like Kenya, Uganda, and even South Africa, there's also an attempt to work with traditional healers, because the first point of contact for many families is privately to consult their traditional healers. Now, what Professor Ndete, who's one of the members of World Association for Psychosocial Rehabilitation, has done is to run workshops with traditional healers to teach them the basic symptoms of presentation by patients with who are mentally ill, and say, this is how we can help. Then the traditional healers say, we notice mental illness in this way and that way, but we also realize our limitations. Help us stabilize them, but bring them back to us. So that concept is taken further into practice in Uganda, in the Makerere area, by Professor Musisi, who says that when the patient is still in hospital, they invite the family, they invite the traditional healers, if they are there, to come and talk to the patient and the doctors to understand the nature of the illness, the presentation, and the medication. So when the patient is discharged, those people become the support system for the patient. So this now brings us to the model that I think all countries are trying to follow. Take people out of big mental institutions, but work with the community-based organizations that are closer to where people live, and engage the family and other support systems like the churches and so on, more and more. Thank you very much.
Thank you for that update, Dr. Solomon. Dr. Murthy, Dr. Murali, you want to say anything to Solomon?
Yeah, I think we had also been discussing some of these issues where one of our colleagues in Madhya Pradesh has done similar thing. Like at that time, I was also involved with them, where we were training OJAs to take care of the thing. And they used to tell that we can't manage few things and we would like to send it to a specialist. So initially psychiatrists were not very happy about that, but then later they found out that by training them, they will send referrals to the psychiatrist. Now that is one example. I think we share a lot with the most of the African experience and ours, especially with South Africa and thing. I think that's a great sharing. Thank you, Solomon, for that. And I also saw Chandrasekhar raising the hand also.
Yes. Dr. Chandrasekhar. Dr. Chandrasekhar.
If he's not coming, I'll just make a very small point. The
Yes.
point which George made about religion and issues, it has a very, very complex relationship. Do you know that the word cretin, which described the mental retardation, came from the word Charitian? That means Christians were kept as protected in the seminaries. That's how the word cretin came, you know. And also we know that Martin Luther King allowed mentally retarded to be drowned in the rivers and things. It's a very complicated type of things. Even in the current situation, I think the point which Murali made, which was made by Dr. Kapoor in 1974 paper in British Journal of Psychiatry, we must learn to recognize the mutuality of traditional healers' beliefs rather than converting them into superstition and things to be abolished, because many of them have their own role to do that. Thank you very much.
Thank you. Dr. Chandrasekhar. Okay. Dr. Israel says an excellent talk, Dr. Murali, thanking Dr. Murali for the same. Any more questions?
I would like to make only a statement, not.
Yes, sir. Yes, sir.
You see, in the Bible, it's mentioned many times that Jesus drove away the demons. People were possessed and they're causing, hurting themselves and others. And Jesus healed them and the demons were driven away. One occasion, one person was with 9 demons in him. So they're all mentally ill. I mean, persons with mental illness. So there is an evidence. I mean, everybody must be knowing this one. It just came to my mind. So I thought I'll just share it to you.
Thank you, Dr. Murali. You want to respond to it?
I have a question.
Yes.
I'm Dr. Samuel.
Yes.
I have seen 2 cases in my own family. They were disturbed and taken to mental ornaments in the worst condition. I have seen them. I have helped them to take there. I have seen practically, one is a lady, one other is equal my size, my uncle's son. Of course, after treatment, they have come home. My question is, they have not been completely relieved. Often that gets triggered again. That's what I have seen. But after so many years, we thought that it will be settled. Yet, even recently, I have seen getting angry, beating his wife. So many things happen. Is there not any permanent solution for such cases? Once the treatment is over, they are fine?
Thank you, Dr. Sam, for the question. Dr. Murali.
Yeah, that actually there's a small percentage of the people, in spite of all forms of treatment, can remain chronic. We call it as chronic. And then what will happen is that the cure issue will not be there, but we are talking about functional recovery. So there will be symptoms in between, And it is again multifactorial. It's not just because disease alone. It is the environmental factors also play a role in the reactions of the person. So that is where we also talk about family education, family's tolerance, and we are talking about a tall order, but at the same time, over a period of time, we have found that it is successful with families if we can engage them over a period of time. That is the thing. There is no easy solution for any of these things, especially that small percentage of people.
Thank you, Samuel Mohan.
Yes. Yes, sir. It is no, I am not raised.
Okay. I see your hand.
No, please go ahead. I'm not.
Okay. Any more questions? Any
Chandrasekhar is
comments?
connecting. Chandrasekhar is connecting now.
Okay. Dr. Chandrasekhar. Dr. Chandrasekhar, your question now or your comments? Probably some connection problem. But yeah, this Samuel Mohan questions about demon possession as, the evil spirit demon possession as, all mental illness are considered. This is very true in the biblical tradition. Old Testament has many references where the mentally ill persons were termed, categorized as mentally ill. They were possessed by demons, including the story of a king who was singing in the street, and people thought that he was led by the evil spirit. And ancient communities, Indian traditions, almost all mental illness categories were considered part of the demon possession and evil spirit. But we are in a different world. And that world, we do not go to that extent of everything as demon possession. Therefore, we need to have adequate measures to respond to people, families, communities, which is, which has a lot of negative impact when this demon possession concept controls our minds. I think I remember reading an article in a research article, the Levant La Foundation of, I think the Padukon, where they have made, it was 16 or 17, 2016, 17, made an expanded survey in the Indian cities. Among the educated, employed class, including IT professionals, more than 60% of people, they said mental illness is a problem and we cannot accept them if we are living in the same home. So this is something very important that is part of the tradition, how the tradition negatively impacting and control us. That's one point I wanted to make on that question. Any more? Yeah. Dr. Jan, yes.
Dr. Chandrasekhar. Okay.
Hello?
Yes, we can hear you, Dr. Chandra.
Some connection was lost.
I know.
Yes, sir. I wanted to, it was a wonderful lecture, actually raising the issues regarding why people get back into the society, how well they get rehabilitated. So the essential of the speech was that, everyone should get good treatment. And I wanted to thank Murali, and I wanted to talk about that e-Manas, I think Dr. Murali was mentioning about e-Manas website, where we are allowed to enter patients' details also. But as far as this confidentiality is concerned, what happens is the basic medical record is entered into the e-Manas website, and no person can open it without the mobile passwords from the patient. So that has been taken care while we constructing the e-Manas website. And we make sure that patient confidentiality is maintained, and nobody can open the EMNS website without that, the message or that numbers, which is to be given only to the patients. And even the clinician, the treated clinician cannot open the EMNS website. Of course, the hospital records can be opened anytime by the clinician, but is data which is entered into the EMNS website cannot be opened by any other person without the willingness of the patients. I just wanted to make comment on it.
Thank you very much. Dr. Murali, any comment on that?
No, not only that, it almost takes a lot of time if you want to get all the data in Word. And they also say that if the patient and party refuses for that, we cannot. So that is not going to be a foolproof system. There has to be some, we may have to change that. That's okay. Because it's in the developmental stage, I hope that it will become a very major success. That is one thing. The last thing I wanted to say is that I'm extremely thankful to all of you for the thing, especially Professor Mohan Isaac leading this Golden Jubilee lectures. And so thanks for giving me an opportunity like this.
Thank you. Dr. Mohan, any remarks from your side?
Thank you. Thank you very much. I just want to say that it was a very useful lecture. We have always wanted to have Dr. Murali come and talk to us, and it has occurred. So we are delighted that these lectures are listened to by people afterwards, because even this morning I was talking to somebody who told me that sometimes I'm not able to attend the lecture, but I always go back and get the recorded lecture. So I think Murali's lecture will be recorded and will be added to the collection for people who have not been able to listen to today's lecture. I just want to make 1 or 2 points. One is that even today's lecture has been widely attended from various places in India. Solly, of course, is attending from South Africa. He is somebody who is deeply interested in psychosocial rehabilitation, and he has been an active member of the World Association of Psychosocial Rehabilitation. We note with great satisfaction that one of the person who has attended all our programs is Dr. Juma from Paripurnata, because the Medico Pastoral Association, Dr. Murthy referred to Joyce Romani, and many others refer to, including Father George Varghese referred to Joyce Romani. So we have, the participation from a lot of people, including the PhD students who are attending from Kohima, if I heard right, that is Nagaland, and a lot of people have been attending. I see that Dr. Anil Kumar from Trivandrum, who is himself interested in rehabilitation, community psychiatry, has been a regular attendant. So this is one point I wanted to mention, that these will be available. Now, the second point is Dr. Ajit mentioned that also, although we had planned 6 lectures before the August Golden Jubilee and 6 lectures after, but because many people have expressed a desire continue to listen to these and these being available, there is a suggestion that we continue. Of course, each month of the year, there is something or the other occurring. For example, 8th of March is the International Women's Day, 30th of March is the World Bipolar Day, come May 24th is the World Schizophrenia Day. So MPA is anyway involved in many of these observance of many of these days, like September is the World Suicide Prevention Day, 10th of October is the World Mental Health Day. So I'm sure the committee will seriously consider, and maybe if there is so much interest, continue these lectures. There are, of course, very eminent people who will be willing to support and assist Medico Pastoral Association to continue these lectures. Now, the third point I would like to mention is, of course, I don't want to add on to anything, but Father George Varghese mentioned about he was doing his case study during the 70s when the early days of Medico Pastoral Association, Joy Ceremony was there. His case study is about schizophrenia, but his question was about possession, which is very much there even today. I am a Christian. Of course, I'm not a scholar, but I have read the Bible, particularly the New Testament. And since it's a small group, I can tell that I do read it every day. A very small section, maybe 10 verses or something like that. So this is something, I mean, the exorcism. Bible scholars have said that it is only in the first three chapters of the New Testament there is demon possession and exorcism by Jesus. But it's in the fourth chapter. There are, of course, Bible scholars here, Father Joseph, Father George Varghese, so I'm not making any comment. But in the fourth chapter of the New Testament, John, they say that Jesus himself was possessed by a demon. It is not Jesus removing. Anyway, it's a very complicated issue. Then I have also looked at, the Shakespearean literature, which I've been interested in Shakespearean play. And as you grow old, when you get more time to read this, you go back to some of these. And in King Lear and Macbeth and all that, there's so much of demon possession and all. So it is a very complex issue. Even today, people talk about this, not only here, even now I do my primary clinical work in Australia. Not all people, but there are several people. Australia is a very multicultural society. People from Eastern Europe, people from various other parts of the world who are Australians, they talk about this. But I think the best approach is what Dr. Srinivasmurthy mentioned. We don't deny anything. If we, as clinicians, make a diagnosis that this is a bipolar disorder, this is, schizophrenia, etc., then of course we manage them. If they have belief, they want to go and pray. Maybe now there are many churches which are also have expertise in exorcism and removing spirits, etc. We have no problem, no fight with them. We allow them. I mean, somebody else also referred to the Dawa and Dua movement, which is now very faithfully, very successfully done in Gujarat, in Tamil Nadu. In fact, in the place where Erwadi tragedy took place, there's a government-run hospital side by side with the dargah. So I think faith and modern approaches to managing people with mental health problems can coexist. And I think it will continue to coexist for a long time. And the last point I want to mention is about what Dr. Samuel said. It is, we do know that the people, especially with a diagnosis of schizophrenia, not all of them will completely become well. As Murali highlighted, they can be given functional recovery. I mean, he gave the good case and the bad case. In fact, the good case, which had a good recovery, he dedicated it to Robert Paul Lieberman, who first wrote in the early 90s about recovery-oriented mental health care and recovery for people with schizophrenia. What recovery is not really cure from disease. You see, like many of us in the audience, I'm sure, are taking medications for blood pressure, or taking medications for diabetes. Is it cured? Can you stop your medications for diabetes and say that I've been cured of diabetes? No. Of course, some people might claim I'm taking this herbal medicine, now my sugar is, but it's only short-lived. So there are unfortunately some medications where you have to continue the treatment intervention for a long time. What is most important is your functional recovery. Are you able to lead a normal life with a meaningful quality of life and contribute and feel fulfilled? That is what matters. So the case that Dr. Samuel mentioned, that some people who became better, he rightly gave them the advice, they went to them, has got better. But his observation was they have not become completely well. There are so many disorders today. Forget about mental disorders. Physical disorders where you don't become completely well. You have to be on medication, but we don't complain. Nobody complains about diabetes not being cured. In fact, now they said India is a diabetes capital of the world. More and more people are getting diabetes. Nobody gets cured of diabetes. So I think this small proportion of people with schizophrenia who don't get completely well is a part of reality, and we have to accept that. I want to once again thank Murali for a very good lecture, which evoked a lot of discussion. And back to you, President.
Thank you, Dr. Mohan. Dr. Ajit.
Sorry,
I want to say a few words.
Go ahead. Yes, sir, Mr. President.
This is pertaining to Dr. C. Mohan's comment that in the New Testament, the Pharisees and Sadducees always they were trying to find fault with Jesus. When he was doing miracle, when he was throwing out the demons in the people, these people charged him, "You are the demon possessed." It is not Jesus demon possessed. These people charged. These Pharisees, Sadducees, who put Jesus Christ on the cross, who put him to death, because they were always trying to find fault. It is not that Jesus was possessed, but he healed thousands of people who were possessed by the evil. What I want to say is, today India is 80% of the population are from villages. From the villages only all these evil forces, demonic forces are there. These things we are not considering. Doctors are not considering all this. Only if anything come to the hospital and urban problems only they consider. These 80% of the problems in the thing is 100% it is true. It is demonic, evil possessed. I witness to that. I am there. This is what I want to suggest. Thank you.
Thank you very much, Dr. Ajit.
I think we should have a separate presentation looking at possession as a phenomenon scientifically, but that apart, I have some very serious reservations. Dr. Kapoor, whom Dr. Murthy referred to, and Dr. Mohan didn't mention him by name, but integrating traditional healing with medical practice was something advocated in his paper and later in his book. But I have grave reservations about certain traditional practices. Exorcism, which we have been referring to, is sometimes so inhuman, maybe well-intentioned, but flogging people with certain tree branches which are supposed to have some kind of a healing power is something that happens in rural Karnataka even today. It's much less today than it used to be, but we used to get these people in the Nimhan's OPD, come with chains, and also these, in case the doctors wanted to use those branches of those trees to drive out the spirit, they had not succeeded, the doctors may succeed. This is an actual personal experience, but this goes on. In Pune, there was a so-called godman who promised salvation for every troubled soul. His method was to take women patients to bed. Another horrible practice that's going on, with a related phenomenon, is the godman who is now under the scanner, Ram Rahim. He feels that sexual frustration is the root of a lot of distress, true in its own Freudian right, but he uses himself as the healer for this frustration. I think we have to be very careful when we talk about integrating traditional healers. They must be scrutinized. It should not be just because it's tradition anthropologically very nice. It's not the right approach, I firmly feel.
Thank you, Dr. Ajit. Dr. Murali, anything final? Okay. Religion.
Thank you.
Okay, when religion is healthy, when religion is pathological, is something that we need to have much more deeper discussion. As Dr. Ajit said, probably we will have another lecture on this at a later point of time with somebody who is expert in the field. Today, Dr. Murthy, Dr. Murali has given us a very profound talk with discussions about the humane side of psychosocial rehabilitation, calling our attention to, especially to human rights and the rights of the patients, which is very important for us to look at and be aware there are certain rights, privileges that they are entitled, which all of us as rehab centers, professionals need to address. And the second aspect of Dr. Murali's talk was about being human, more empathy, concerned about people who are around. Particularly, I'm looking at those derogatory words that people used. So many, as a child, I heard many people calling them mad people on the street. I think I also called a few people mad when they were, going back from school in the group. But that was 50 years ago, 60 years ago. Now, even now that is still a prevalent thing, calling names, derogatory names, and not giving them the right to live. So that is the example he gave us. He gave us, a patient has come back to the hospital back saying, better to live here and not to the world out there. This calls for the empathy, the sensitivity, the compassion with which we need to work in our rehab centers. Thank you, Dr. Murali, for this talk, helping us with this understanding of, being more human in our approach to people at home, communities, and in the rehab centers. Thank you so much. Over to Reshma.
I thank Dr. Joseph George for having chaired the session. Thank you, Doctor. It was a very wonderful, nice interactive session. May I request the audience to reach out to us on our email ID if you have any further questions or comments. The email ID is shared in the chat box. Thank you. We have now come to the end of the session. May I request Mr. Alphonse Kurian, Honorable Secretary, MBA, to deliver the vote of thanks. Over to you, sir.
Thank you, Reshma, for comparing this program so wonderfully well. Thanks to Rohini, who had taken all the efforts for seeing that our Golden Jubilee series of lectures of 12, what was planned, has gone ahead with every month. And as Dr. Mohan Isaac and others mentioned, we are thinking of continuing this hereafter because of the good response. And even today we have seen, I think the question answer could still continue if we were still alive. I mean, still on, but everything has to end. And it's my duty to pleasure and privilege to propose a vote of thanks. Dr. Murali, it was a wonderful talk, and I'm sure all of us have enjoyed it. The community participation to the latest e-winners and touching even the latest items in the newspaper of yesterday and today, and even something what happened in MPA just 3 days back on the craft design training I could see on that slide of yours. Thanks a lot for this wonderful presentation, and I hope this e-winners, we get more clarity of it as we move on ahead. To thank the residents and the staff of MPA for that wonderful invocation. It's always an opportunity we get our residents also to get involved in such events of ours. Of course, our president has had 3 roles today: welcoming, introducing, and chairing the session. Thank you, Dr. Joseph George, for everything that you have been doing to us. And our Vice President, Dr. Ajit, for welcoming the audience and all the audience who have been here so listening so seriously from across the country and outside too. We're failing in our duty if we don't thank Microlab for hosting, supporting us with a Zoom link. And it was so nice to hear from that Father George Verghese, whom I'm hearing for the first time, was a very old associate of MPA, and we hope we will have more in touch with you. I don't know whether you are in Bangalore or elsewhere, but we'll try to connect with you and have some more contacts about what was the beginning of MPA, though, of course, Dr. Mohan Isaac and all others would be knowing much better. Well, everything has to come to an end, and I would like to thank one and all for your patient listening and joining us. And I hope we'll be able to continue this series, and we will be able to go ahead and meet once in a month. And yes, I think Father George has mentioned that he is in Pune. Well, now with mobiles and WhatsApps and all, we can definitely keep in touch. Thank you.
I just want to add something which I read in the chat box just now. As Ajit and Alphonse were talking about extending this, this is a chat from Dr. Salma Tajuddin, who says, I look forward to many more such lectures. So I think at least, there is a need for such lectures, and the committee, I hope, will consider continuing these kinds of monthly lectures and inform everybody so that anybody who is interested can log in and attend, and if there are recorded ones available, they can even listen to later. Thank you very much.
Thank you very much, Dr. Mohan and Reshma for the MC and Dr. Murali for the excellent lecture, and looking forward more from you in the coming years. Thank you so much.
Thank you all for joining us in this evening for this wonderful program. Thank you, everybody. Please visit and follow us on our YouTube page where the recording will be soon shared. Thank you.
Bye-bye, everyone. Have a good evening.